Welcome back, everyone. We're so thrilled to be here with Dr. Marie Clements-Baker, who's an assistant professor at Queen's University. In this, our second interview for this year's #CArthritis event on Facebook Live and Twitter Live, and this is co-hosted by Arthritis Broadcast Networks and my colleagues at Canadian Spondylitis Association and the Arthritis Patient Advisory Board of Arthritis Broadcast of Arthritis Research Canada. I should get a medal for just saying all that at once. And now I'm completely winded, which is probably a good thing. So we're really happy you came back, and we're really thrilled that you can be here with us, Dr. Clements-Baker. May I call you Marie?
Of course.
Thank you.
Yes, please do. I know, my name is a mouthful.
It is a mouthful. And you add the doctor on there, and it really becomes a tongue tripper. So we're super happy to have you. Thank you for giving us the time. We know the meeting's about ready to kick off, and we know you're probably anxious to participate in the opening session. So we're going to keep this super simple, super snappy. We're going to go to our audience and ask her some questions. So folks, as you're listening to Marie, please form some questions and type them and get them in. And I guess we're going to start at the beginning. Tell us a little bit about yourself, Marie. What specialty, if you have one within rheumatology, you focus on, and sort of your day-to-day life in rheumatology.
Okay, well, and thank you for asking me. It's my absolute pleasure to be here and to be able to chat about this. So I work at Queen's University in Kingston. I am the program director, which means I supervise the teaching program for the residents at Queen's. I also do, I see general rheumatology, so I see a lot of patients, but my specialty is in vasculitis, so I see a lot of vasculitis patients. And the other thing I see is the patients with interstitial lung disease who have an underlying question of connective tissue disease. So I see a lot of those patients in combined clinics. I do some combined clinics with other specialists there. So that's kind of my passion. I love following that, but a lot of general rheumatology too.
Yeah, which is probably somewhat typical for most of your colleagues. You have a niche sort of interest, but you're generally looking after a lot of different patients with autoimmune arthritis.
Absolutely.
Yeah.
Absolutely.
The diseases that you focus on and have a keen interest on, such as vasculitis and interstitial lung disease, and those are really significant diseases, and often sort of refractory or kind of untreatable or really sort of poorly managed. And we read a lot now about sort of some of the newer therapies that are being tested in diseases like vasculitis. Is there promise in that area? Like, is it looking good?
It's really amazing. So I do a lot of the conferences. There's some very specific vasculitis conferences, and when I started going to them, there was maybe a couple hundred people there. Yeah. Now there's 600 people, and that's worldwide. That's all the people across the world who are really interested in vasculitis. And it went from one small room with posters to now lines and lines of posters of research, meetings, twice a year for the Vasculitis Research Consortium of different ideas.
Yeah.
Therapies that are coming out. So it is really exciting. And even for simple vasculitis like giant cell arteritis, we have great new therapy with the IL-6 inhibitors.
Yeah.
So it's really exciting. Something we used for rheumatoid for a long time.
Totally. And I think when you talk about the growth of a meeting like that, I think for our viewers, it's a crescendo of knowledge that begins to build, and people's ideas, they use those ideas as scaffolding, to bring them to the next sort of level.
Absolutely.
And that's super exciting. And I just, as a layperson, we're seeing sort of that kind of chatter, and it even filters through down to the lay level. So I guess if you were to say your top 3 things that you're excited about in this specialty area, what would they be? I'm sure that you've got a list of 10, but I'm going to limit you to 3.
Okay. Well, I think, so for some, in this area, one, we've got some new breakthroughs in interstitial lung disease, and we're going to be seeing some of that at the meeting, or this meeting, with some of the new therapies that are there. So I think that's really exciting. For people with scleroderma, for example, before there used to be so little that we could do, and now we're actually with all the research, people have been working and working and working at this, and we're finally getting some things that are actually going to change the outcomes for people, and that's exciting.
Yeah, that is exciting, and I think that for that community, we have to change our mindsets from one of just the usual dogma, well, there's nothing that can be done, to coming on board with you and going, okay, there are things that we can do and implement into our lives, such as new treatments, perhaps. I know that you're here and you're going to be giving a national update, and we're going to steal the information first here in the ABM broadcast booth. And your talk is titled CBME or ME. There's no turning back. So that is a heck of a provocative title. Can you give us sort of an update or some sort of the key messages that people are going to be left with after your talk?
So CBME is what we call competency-based medical education. So in rheumatology, it used to be you do your 3 years of internal medicine and then you had 2 years of rheumatology.
Yeah.
And so that means that there's kind of a time-based assessment, and people sort of make their way through that. And there were gaps in the way that was done. Our programs were good, but the competency-based method is more a method of making sure that the residents can demonstrate and show that they actually are trustable to do multiple different tasks. So we're watching them much more closely, and we're giving a lot more feedback. So it changes. Some people in medicine are very type A.
We know that.
They don't like to have a less than outstanding evaluation, and we're trying to move away from that so that you have constant low-stake evaluations, so that we're watching the residents saying, hey, that was okay, or that was good, but if you try this, or try that, it's going to make it actually a little bit better. And I think the patients are going to see that, more observations happening, and it allows them to have a bit of feedback and understand that we're trying to make things better for their experiences.
Well, it totally would loop in and improve communication. You can see, that just comes clear to me, right, just listening to you describe this competency-based sort of evaluation. It also is a practice we've been using in sport, for heaven's sakes. What do you think coaching is all about, right?
So this is absolutely it. So we're trying to move to this coaching type mentality. So that's exactly, you already know.
I'm a former athlete, so I know all about coaching.
So this is exactly, it's like a safe environment where we're coaching the residents to move ahead. And actually, my last slide for my presentation is a picture of a coach with the stopwatch watching the runner come across the line.
That's we got you the breaking news, even the final slide. Yeah, I love it. Yeah. Well, congratulations on that work, by the way. We as patients, that we end up with these people when they graduate medical school and they go out on the front line and start delivering care. To think that what they're doing is just simply taking tests. We're not check boxes. Mm-hmm. We're real people whose daily, sometimes hourly needs change. Believe it or not, my mood may be different on one visit versus another visit. And it sounds like you're coaching these youngsters into your field in a more human kind of way.
In a way, absolutely, in a way that it's not threatening to have feedback. It's okay to have somebody observe you and tweak things. And it's surprising. Sometimes people can talk like they know a lot of stuff, and you get surprised when you go and actually watch somebody doing something new. Wow.
Yeah.
Okay. And so that's what a competency-based medical education does. It encourages us to do a lot more. So as patients, you're probably going to be, if you work where there's residents, you're going to see a lot more observations happening.
Yeah. So here's what I want to ask you next, is you think about this meeting and this 2020 vision theme, which Tom Appleton told us about just before you came into the booth. And we asked him, so using his 2020 vision, what does he think is going to play out over the next 3 days here in the meeting? So what is it that you're looking most forward to, Maria? I'm sure you know the agenda. Yeah. Like, what do you hope to get out of it as a physician, as a colleague?
So this meeting is always wonderful for networking, so I love being able to touch base with other people, but actually one of the talks I'm really excited about is the microbiome and the inflammatory diet.
So are all of we, by the way.
And so many patients ask me that, and I say, we don't have good evidence on this. Yet, how exciting is that to think that, the microbiome, changing your diet, tweaking things, avoiding certain things, adding things in could actually change. Might not, maybe it's preventative.
Yeah.
Maybe it helps,
If it's additive, go for it, right?
Exactly.
And also, is it going to hurt me? Like if I eliminate something, I think I can speak for my patient organizational colleagues. It's some of the most common questions we get. One of them is, what can I change in my diet? What can I do? Should I do a keto diet? Should I do plant-based? Should I,
nightshade
vegetables? Trust me, all of us have done them probably all at one time.
Yeah.
So that's really exciting. And we'll all be sitting like around you in that meeting because we want to see your reaction when you get your favorite talk. When you think about your patients, we want to know, what are your 3 clinical pearls to your patients? And I kind of keep it high level, obviously. This is not meant to be prescriptive in any way. But just conceptually, what do you hope your patients walk out of your clinical visits thinking, feeling, doing?
So one, I want to make sure that, my patients feel listened to, because I want my patients to share with me, because if the patient doesn't buy into what the plan is, they don't feel comfortable, so I want them to tell me. If they don't feel comfortable about a medication or something, we need to talk about that. So it's a patient-centered plan. So that's the one thing, is that I want to hear that from the patients. And all physicians need to hear that. Sometimes it's hard to do that, but it's something, that's one thing that's really important to me.
That's fantastic.
Yeah. I think something else that's really important too, I think, is that I really encourage them, one, to try, and we don't know exactly what the diets are, but eating healthy and moving. So as much as you can, try and move. It doesn't have to be fancy, but try to move. Get up and move.
Well, what would you prescribe? We're not prescribing here, but what do you recommend? Every 20 minutes? Does it depend on someone's current ability to move?
Absolutely. It totally is. For some people, it might just be, you're in a chair and you're just stretching your arms and you're just straightening your legs to try and keep your quads strength. For other people, it's what you can tolerate. So, getting up and doing a walk. You don't have to be on the treadmill. You don't have to be, doing something fancy, going for a walk, or just getting up and down out of your chair. Little things. It's within, depending on where your disease is at. If you're actively inflamed, of course, you can't do much. But when you're trying to recover, little bits, and sometimes, the Arthritis Society is a great help with some of that, and physiotherapy, if we have coverage, all of those things are great.
And I think specific to sort of patient-generated material, our organization, Arthritis Consumer Experts, has all kinds of courses people can take online, all kinds of great information. Same with the Canadian Spondylitis Association and Arthritis Patient Advisory Board. That we all are rich resources, and you've got our contact information through this programming. So we encourage people to pick up on what Maria is saying about the movement, and try to incorporate that into your lives as much as possible. We're just going to take a pause here and see if our fearless producer, Anita, has any questions for us from the audience.
This is in regards to your teaching. So how do you think this new form of teaching will impact patients who are treated by the students?
So I think, any patient who's treated by a student or a resident is being supervised by a physician. But what's going to happen is that you're going to see the physician coming in and observing more often. So you're probably going to see a little bit more of the physician, the actual supervising, or the staff faculty sort of supervising this a little bit more. But in the long run, I think it's going to be a benefit to the patients, because I think we're making everybody's more accountable. The process is transparent. So I think that's it's a good thing.
Yeah.
It's a big transition, but it's a good thing.
Are other programs, just tagging off of that question, are other institutions, other programs looking to adopt this type of approach?
So I should preface this by saying this is mandated by the Royal College
fantastic.
of Physicians and Surgeons. So in fact, Queen's did adopt it early. So the dean at Queen's wanted to adopt it across the board because he felt strongly about the concept, and so we started a bit before the other institutions did. But rheumatology went live with CBME in July of 2019.
Oh.
Yeah, so we are already in the thick of it.
And you're evaluating it, obviously.
Absolutely.
Yeah.
So we're just, actually, we haven't even probably done it long enough to evaluate it, because we are going to take a step back and say, did we choose all the right skills and all the right and trustable activities? Are the forms working? Are we doing enough assessments? How is it working?
So baby's not walking yet,
But just starting.
just starting to walk.
Crawling.
Okay. Any other questions, Anita? No, that's good for now. We welcome more questions from Marie. We will port them over to her and get answers. We won't inundate you, we promise. Those that can be answered through our collective resources that are always vetted by our clinical advisors. We just want to thank you so much for coming in. It's been really delightful getting to meet you and talk to you. We welcome you back anytime. If you just crash the door, you can come in whenever you want and have more interviews if you've learned something that you want to definitely get out to our audience. Yeah,
That's lovely.
for sure.
Yeah, it was a lot of fun.
Open door, as long as there's not someone already in the seat, you're welcome.
Well, fashion doesn't work.
Yeah, exactly. We're not stacking people up here. We thank you for joining us for this delightful interview with Dr. Marie Clements-Baker from Queen's University. We hope you enjoy the meeting and that you learn tons, and we wish your patients well as all of those out in Facebook and Twitter land. Thanks for joining us. Come back soon.